You have amenorrhea, oligomenorrhea, or menorrhagia, galactorrhea, premature ovarian failure, infertility, decreased libido, precocious or delayed puberty, chronic heart failure. I had one patient who was going from doctor to doctor for urticaria. They were not treated by properly. They were giving all antihistaminics, steroids, creams, lotions. Nobody looked at the thyroid. Invited it as hypothyroid. Treated the hypothyroid, it disappeared. So many are there in this experience. One woman came galactorial. She passed her childbearing period. She's around 30, 38, 40 years. Already she had two kids. Started having galactorial. Then we evaluated. Found out hypothyroidism with hyperprolactinemia. Hypothyroidism can cause hyperprolactinemia, which can lead to galactorial. Menstrual abnormalities, many women, they come with menstrual irregularities, go to the gynecologist, and ultimately come. So ultimately they come land up with us and we come. So these are the underlying diseases. Whenever you see, you have to suspect the hypothyroid. Okay. Hypothyroidism and diabetes. Approximately 10% of the people with type 1 diabetes are having hypothyroidism, because part of the hypothyroidism is autoimmune thyroiditis. Type 1 diabetes also is autoimmune. In diabetic patients, examine for goiter. Okay, TSH measurement should be done at regular intervals. Now, I am going to take you through the algorithmic approach for hypothyroidism. All clinical features and all we have discussed already. Biochemistry also we have discussed. Now I'm going to look at the algorithm. Algorithmic approach. What you have to do? First of all, you have to measure the TSH. No FT4 here. There in hyperthyroidism, both have to. Here TSH alone should be odd. Elevated TSH. That means pituitary is informed that there is no thyroxine in the blood. That's why it is secreting more TSH. Okay, then look at the FT4. FT4 must be very low. Low FT4 and elevated TSH means primary hypothyroidism. Low TSH is low, the TSH is high, FT4 is low, primary hypothyroidism. Then you have to order the antibodies, TPO antibodies. Antibodies you have ordered, TPO positive, TPO negative. TPO positive means autoimmune thyroiditis, producing hypothyroidism. TPO negative is primary thyroiditis without any artery. This one. TPO positive is Hashimoto's thyroiditis. TPO positive means immediately you have to put them on T4 replacement. That means TSH is elevated, FT4 is low, primary hypothyroid confirmed, TPO positive, Hashimoto's disease, T4 is the treatment. Suppose it is TPO is negative, then it could be other forms of primary hypothyroidism. It is only for the diagnosis sake, otherwise treatment is going to be T4 replacement. Supposing you say FT4 is normal, but the TSH is elevated, that means there is still a little bit of hormone left in the body. That is why it is called subclinical hypothyroid. What will happen is thyroid is secreted into the vesicles of the thyroid gland as thyroglobulin. This thyroglobulin is stored in the gland as a combined molecule. This will be slowly released on demand on day-to-day basis. So the thyroid that is secreted by you till today is stored in the bank called thyroid. And for the bank to exhaust, it will take some time, 2-3 months time. Then no one knows a thyroid hormone secreted. In the meantime, TSH really is elevated. So that is called subclinical hypothyroidism. So that means the thyroxine that is manufactured already is trying to keep the body going for some time, like reserve petrol. So the car is going in the reserve petrol. Sometime it will stop. Once it is in the reserve means it is already on the lower side. That's subclinical hypothyroidism. Then there's a big controversy whether subclinical hypothyroidism should be treated or not treated. That also we will resolve it. Okay, then do a TPO antibody. If the TPO antibody is positive, then there's no question of waiting for some time. Or if the woman is pregnant, then no point. Two conditions. So if you find a subclinical hypothyroidism, means TSH is elevated, FT4 is normal, patient clinically doesn't have any hypothyroid features. I did an antibody is positive, it is autoimmune, I must. Woman is pregnant, I don't want to risk mental retardation, so it must be. The two conditions. So, or the third condition, mother having hypothyroid. If there is a family history of mother or sister having female member of the family, sister or mother having hypothyroidism, pregnant woman, TPO positive, subclinical hypothyroidism needs to be treated. Otherwise, we can wait and follow it up every 6 weeks to 12 weeks. The moment it becomes frank hypothyroidism, primary clinically biochemically detectable hypothyroidism, then of course you will. Okay. Now you understand when to treat subclinical hypothyroidism. What is subclinical hypothyroidism? No clinical features of hypothyroidism. Elevated TSH and FT4 is still not. These people, 50% of them will go into frank hypothyroidism. Who are those? Mostly TPO positives. We have to treat pregnant women for risk of mental retardation and people who have a family history in the female members of hypothyroidism. Okay. Now, TPO negative, what you do? Patient is TPO negative, non-pregnant, no family history. Every year you keep on following. The moment they become hypothyroid, you treat. That's okay. That part is what. Now, TSH is normal, and the patient is having clinical symptoms of hypothyroidism. That means the primary hormone from the pituitary, the stimulating hormone itself is not there, probably considering the pituitary. If you are not considering pituitary origin, then no more tests are. If the TSH is normal. Suppose the pituitary hormone, the pituitary possibility is still I'm considering about the secondary hypothyroid. Then measure the FT4. If you measure the FT4 is normal, TSH is normal, nothing need. That means no tests are. If the FT4 is lower, but the TSH is normal or elevated or depressed, that means it is primary hypothyroidism, secondary pituitary hypothyroidism, sick euthyroid, or the patient is taking altroxin. Okay. Hormone replacement. So, how do I replace the hormone? What is the goal? Goal is to normalize the TSH level regardless of the cause of hypothyroid. Treatment, once daily dosing only you have to give, not 3 times daily. I have seen some prescriptions, thyroid hormone, morning, afternoon, night. It's wrong. You should not prescribe like that. Always on empty stomach. Levothyroxine only should be used. That is 1.6 micrograms per kilogram per day, upper limit. 1.6 into 60 will be 100. 60 kilogram weight, 1.6 into 60 is 96 micrograms, roughly 100 micrograms. Always monitor the TSH level so that you don't overshoot and overcorrect the hypothyroid at 6 to 8 weeks interval. It's very important. So should not overshoot. So monitoring the TSH levels is very important. Many causes for hypothyroidism we have discussed. Only one treatment. Treatment of choice is levothyroxine. Branded thyroxine should be used. Consistency of the brand is important. Today you use Abbott's brand. Tomorrow you use Burroughs Wellcome brand. Like that you should not change. If you have Thyronam, Altroxin. So don't keep on changing because the brand bioavailability of the drug between the brands is different. 100 micrograms of Burroughs Wellcome may not be the same as the 100 micrograms of Thyronam. Whatever is the brand that you have chosen, stick to that brand. And unbranded thyroxine, generic thyroxine, don't. And only use branded thyroxine. No divided doses, illogical. Always give in the morning before empty stomach. Why? It is best absorbed without any further reason. Desiccated thyroid extracts are available in the market. They call it a thyroid extract. Never use them because the amount of thyroxine that they contain is very variable, and we don't know how much the patient. Likewise, combination of hormones T3 plus T4, this will work better, sir. Somebody will be, no, I don't want T3 at all. T4 only is required. T4 has to become in the body T3 by removal of one iodine. It is a tetraiodotyrosine. One iodine is removed, tetraiodotyrosine, and that is the active form. We don't have to give the active form. Body has got enough resources to convert it to the active form. So we only have to give levothyroxine. One condition, because we know T3 is the way through which the end organs respond. When somebody is in a coma, then you have to give T3 by needle. The only indication for T3 is mixed. One Dr. Najima is my junior colleague. She was around 15 years junior to me, a gynecologist. So one day her mother became unconscious and she was admitted in Chennai in a big hospital. They have done all that is the MRI, this one, so neurology has come, everybody has come, diabetes, ketoacidosis ruled out, metabolic encephalopathies, poisoning, all that things thought of. That night, that lady, doctor, my mother is admitted, they are not able to find out the diagnosis, she's unconscious. I asked her only one thing, did you do a TSH? No, said they have not done. Then immediately you said. So she sent it around 7 o'clock. By 9 o'clock, the report came 120. That means what? She is in maximum coma. And she is having features of. Then I asked her, how was she clinically? Sir, she was having hypothyroid. We gave out a treatment for some days. Then we stopped. What happened? She went into coma. Then I told that consultant number I asked of that hospital, called him. Look here, this is myxedema coma. You have to put her on T3. Now immediately start. She was started on T3. On the third day, she got up and walked. And for which already some 60,000, 1 lakh rupees investigations wasted. So not that I'm saying every coma will be myxedema coma, but you must keep that in mind. And the others are not fitting, one by one you are explaining. Can it be myxedema? Looking at the patient, the other day I went and saw the patient. He is clinically very hypothyroid. DTR is on half an hour it is taking when I put the jug. Today I stimulate, tomorrow it is giving the reflex. What clinician you are? It is very evident. See, that person who is treating is a neurophysician, but he must have become MBBS first. After that, MD also has passed now. So he must consider endocrine causes also there. That's what I'm saying is not that I'm finding fault with the doctor. It is quite possible that you might also miss like that. Over phone, I asked her, did you do it? Yes. Because I know the myxedema coma is one of the different. Immediately came the answer in 2 hours. She is having this one. And we started. See how times and sometimes. So T3 replacement always, whenever I get this, I tell the story to the students. Okay. Dosing adjustments are very important. Here the rule is start low and go slow. Don't start 200 micrograms, 150 like that. Start low and go slow. Particularly in the elderly, half the dose only you start. Because unless it is myxedema coma, it is not going to kill the patient. Hypothyroid patient will not die. For sure, of hypothyroid. He may die of something else. He will not die of hypothyroid. So there is no urgency to treat this disease. Whereas hyperthyroidism can produce an atrial fibrillation, the congestive valvular crisis, myocardial problem. It has to be immediately addressed. Your time is there in your hand. So you don't have to hurry and start low and go half dose. Severity and duration of hypothyroid, you see, depending on that, you increase the dose. So how much I have to give? 0.5 microgram per kilogram body weight. 60 kilograms, 30 micrograms. 70 kilograms, 35 micrograms. 100 kilograms, 50 micrograms. Available as 12.5 and 25 and 50 micrograms. 100 micrograms, 200. So you can choose titrating. Suppose you want 37.5. 125 milligram microgram plus 112.5 you can go. So you can go up to maximum of 3 micrograms per kilogram, which means 200 milligrams per day. You can upper limit of the dose. Malabsorption, somebody has got, celiac disease or malabsorption syndrome or irritable bowel disease, then you have to give him increased dose because thyroxine absorption will be less. Concomitant drug therapy should be avoided. Should not combine this drug with other drug. It must be given always on the intestine. Pregnancy, 25% extra. Suppose she is receiving 100 before being pregnant and she becomes pregnant, hypothyroid treatment should be 125. Because this is to cater for the fetal requirement of the thyroid. Otherwise, we will be producing all idiots in the society with mental retardation. I don't want the society to be burdened with brainless people. Already we have enough brain persons. Why do you want to manufacture more brainless persons? Okay, presence of cardiac disease also. Start alternate day treatment. Somebody is a myocardial infarction, myxedema, or hypothyroidism. Don't jump to treat every day. I give this day, alternate day. Some doctor commented, sir, no doctor gives alternate day. I have given a prescription Monday, Wednesday, Friday. And that came the patient the other day. He went to somebody and showed, no, thyroid should be taken every day. Dr. Sharma does not know. He has given alternate day. Probably has forgotten his medicine. He is no more practicing nowadays. He did not read. And I called the doctor. Care this patient is a cardiac patient. Look at his ECG. He is recently stented. He should not be pumped with thyroid. For that reason, I have put. Learn like this and start treating like this. He's a junior fellow to me about 10-15 minutes. Oh, sorry, sir, sorry. So simply you cannot comment. Now, if somebody has written, you should think or read the book. Why it's given like. So the point is here, not to say one-upmanship. In cardiac disease, you have to start low, alternate days, and go slow. That is the start low, goes. Goal, what is the goal? The thyroid, the TSH should become normal. Not the goal, yes, her skin should improve, she should not, she should cold intolerance should go, her weight should decrease, she should menstruate. These are not the goals. They will happen later on. The first goal is TSH should become normal. That's your goal. So all clinical improvements will come later. You shouldn't expect them now. Your goal is to treat to the 30s. How much I start? 12.5, 25, 50, 100. Use the combinations. Every 6 weeks, you keep on upgrading or downgrading depending on the on TSH level. Starting dose for a healthy patient, 1 microgram per kilogram, less than 50 years. More than 50 years, should be 25, less than 25 micrograms per day. Dose increased by 12.5 milligrams if needed at every 6 to 8 intervals. Starting dose for patients, start disease, always 12.5 micrograms. Then go up to 25 or up to 50, 100. Okay, so start low and go slow. This is one disease where you don't have to hurry. So you have to use your brake more, not the accelerator. Yeah. How the patient improves? So how do I know patient is, sir, my skin is like that only. I am still fatty only. I am not menstruating or I am more menstruating. Wait. You feel better after 2 or 3 weeks. It is not like paracetamol giving now after 1 hour check temperature, whether it is reduced. Not like that. It will take time, 2 to 3 weeks you absorb. A reduction in the weight is the first improvement. Facial puffiness start coming down. Skin changes, hair changes, take a lot. That's what I'm telling. TSH starts showing decrements from higher values. TSH returns to normal. So until TSH returns to normal, you keep on stepping up the dose. Actions. Malabsorptions, of course, will have absorption. Reduced absorption can occur with resin used for hypercholesterolemia, sucralfate, ferrous sulfate, soya formulations, aluminum hydroxide, cholesterol hydrochloride. These are the drugs which reduce the absorption of the thyroid hormone. There are certain drugs which interfere with the metabolism of the thyroid hormone. The rifamycin, carbamazepine, phenytoin, phenobarbital, and amiodarone. This amiodarone drug will interfere with everything. If there is a drug that needs to interfere with other drugs, amiodarone is the first drug. Just like, we are asking in the what are the side effects? He was not answering at all. He don't know. Then my partner was sitting, and she could have told stomach pain, gastrointestinal, that every drug will produce. At least you could have passed him. Then I told every drug will produce GI upset. You say some GI symptoms, then we will pass you. Like he said, no, stomach pain. Okay, fast go. That's how we have to pass nowadays the students. You don't even think. Inappropriate dosage. Over replacement as a risk in thyroid. You should always watch for chemically induced or iatrogenic hyperthyroidism because of your excess thyroid. Okay, reduction in the bone density can occur, osteoporosis can occur, tachycardia, arrhythmias, atrial fibrillation. The elderly patients with heart disease, angina, arrhythmias, myocardial infarction can occur. Under replacement risk. Continued hypothyroid state, long-term end organ problems, increase the risk of hyperlipidemia can be there. So it's like, balance. It should not be more, it should not be less. Titrate using the TSH. The needle of the balance is the TSH. If the TSH is going lower and lower and lower, reduce the thyroid. TSH is still upper and upper, higher, then increase the thyroid. Okay. Diet and iodine deficiency. Iodized salt should be prescribed. Selenium supplementation can be added. Avoid thyroid interfering medicine. Foods like cassava and then the yam and all. Cabbage has got some goitrogens. Avoid formula milk. Fish, meat, egg, and these also have to be avoided. Special situations. Subclinical hypothyroidism. This already I told you is a chronic autoimmune thyroiditis. Sometimes Graves' hyperthyroidism, after radioiodine therapy and surgery, they become hypothyroid. That will be subclinical only. Inadequate replacement therapy from hypothyroidism. Lithium carbonate therapy and depressive. If you see a patient with elevated TSH, FT4 normal, is it chronic autoimmune thyroiditis? Is it Graves over-treated with radioiodine and surgery and then post-surgery, post-radiation hypothyroid? Or am I not giving enough thyroid hormone? Or is the patient depressive illness taking lithium? If these are excluded, then do a TPO. TPO is positive, treat the TPO negative, follow every year. Mother has got hypothyroidism, straight away treat the patient. Nothing is going to happen. And then watch the TSH. And then family stuff, I told you. And then I told you about the TPO positive and negative and pregnant. If the one is pregnant, even if she's subclinical, better treat as because we don't want mental retardation. Postpartum thyroiditis. There is one thyroid disease called the PPT, postpartum thyroid, just like PPH, postpartum hemorrhage they have. Here is PPT, occurrence of hyperthyroidism and or hypothyroidism during the postpartum period in women who are euthyroid during pregnancy. That means throughout pregnancy, thyroid is normal. Immediately after pregnancy, either they are hyperthyroid or they are hypothyroid. At risk, patients who are type 1 diabetes, previous history of in the previous pregnancy, PPT, other autoimmune diseases such as Hashimoto's and Graves, they have PPT. Myxedema coma, this is my friend's mother. Okay, infection, trauma, stroke, cardiovascular, hemorrhage, drug overdose, diuretics, these all can precipitate the coma. Signs, mental confusion, hypothermia, bradycardia, older age group, sodium low, glucose low, carbon dioxide high, WBC low, hematocrit low, CPK high, EKG low voltages, myxedema is there, beta carotenemia may be there, patient may have carrot color in the skin, ICU admission, T3 100 micrograms IV 6th hourly. Here is the injection treatment of thyroid, not T4, because we want immediate action. T3 has to be given. 100 microgram ampoules are available. IV 6th-hourly, 500 micrograms of T4 also you can give in intramuscularly. That gets converted into T3 slowly in a day or two. Antibiotics, ventilation, cortisone IV, passive warming, careful volume management are the tricks there. Okay. This is a short notes. SICU thyroid. SICU, what is SICU thyroid syndrome? Total T3 is reduced. FT3 also is reduced. Total T4 also is reduced. FT4 is normal, TSH is. Normally we do only TSH and FT4, but the fellow is clinically euthyroid and the FT4 TSH normal. That means, at the moment he is not hypothyroid, but the total hormones secreted into the blood are less. In such a scenario, you measure the total hormones, you will see the reduction in the total T3, total T4, and the FT3 also. So the 10 commandments, in Christian mythology, you have the 10 commandments. We have commandments here, not 10, but more. This is why I always tell the student, you must have this thyroid commandments. What are they? Highly suspect hypothyroid. Even for you also better get TSH. Sir, I'm very weak, sir. I don't feel like working. When I am studying, I'm feeling sleepy. Check thyroid. Probably. And naturally also you may be sleeping. That's a different story. Not interested to study. Growth and puberty delay. Many children are brought on delayed puberty, hypothyroid, correct. Unexplained depression. The TSH is the test for hypothyroid. TSH, FT4 to confirm the diagnosis. 9 square magic, I have told you, test cord blood for TSH. Every patient who delivers hypothyroid mother, once the baby is born, you must test the cord blood for TSH. If the child is having hypothyroid, you must supplement the infant. Otherwise, it will endanger in mental. All obese patients, TSH must be done. For all pregnant patients, no excuse of not doing TSH and FT. Postmenopause, 15% of hypothyroid. When I give all this list means what? Test thyroid for every fellow. That's not. Pregnancy I have to test. Obesity I have to test. Elderly I have to test. And then any growth retardation I have to test. Depression. Who are the fellows who doesn't have any one of these conditions? That means everybody should. In general, make it as a routine parameter to be evaluated. Once in 6 months or 1 year. Start low and go slow is another command. Use only levothyroxine. Always on empty stomach. Don't change the brand. Avoid empirical thyroxine use. This is, I know some physicians, without testing anything, the patient is obese. Give him some thyroid, he will. No, not like that. Thyroid is a catabolic hormone. It will deplete the bone. If there is no need, don't just give empirically some thyroid without knowing this one. I remember one professor whom we were studying in those days. Somebody coming obese, they used to do thyroid function. But no problem, give some thyroxine. The obesity will come. No, that should not be done like that. It's wrong. Now I'm giving you some questions. You answer these questions. Should a serum TSH be a routine component of the periodic health examination in women? Why women? Men also. WHO also you remove. Women and men. If you are a human being, get TSH tested. Okay, as simple as that. What is the appropriate biochemical endpoint for adequate thyroid hormone replacement in hypothyroid patient? Not skin changes, not hair changes, not menstruation changes. TSH is the biochemical endpoint. You have to titrate to the TSH level. It should be between 0.3 to 4.2, whatever is the lab. Are there risks associated with over replacement of thyroid? Yes. And how do I ward it off? By looking at the TSH frequently. The moment TSH is coming down, that means I'm giving more, bring down the tablet from 12.5 milligrams. You cut down and then. Are all L-thyroxine products therapeutically equivalent? No. Each availability of each brand is different. Should I combine T3 and T4 also? No, you should not. T4 should not be administered. T3 should not be administered except in mixed edema. That too by needle. Question number 5. What is the impact of pregnancy on thyroxine replacement therapy in a hypothyroid patient? So it should be 25% more than the pre-pregnant dosage. What is the impact of breastfeeding on the management of a maternal hypo and hyperthyroid? I have not told about this, but I have. Now you tell me. What does it mean? Mother has hypothyroid. She is breastfeeding. What is the advice? You have to test the baby. The baby is also hypothyroid. You have to give the baby also hypothyroid. Okay. Suppose hyperthyroid. This hyperthyroid drug methimazole is secreted in the breast milk. You should not use. Propylthyroid, radioiodine should not. Hyperthyroid, 3 are available. 3 weapons. Weapon 1, methimazole. No. Weapon 2, radioiodine. No. Should not be given. Weapon 3, propyl. Yes, you give. As simple as that. Question 7. Should women with subclinical hypothyroidism be treated with L-thyroxine? This is $1 million question. Yes or no? Yes and no. Yes, I do a TPO antibody, TPO positive, I treat. I inquire about pregnancy, do a pregnancy test, pregnancy treat. Or already she is 9th month pregnancy, no testing you can do. And the third one is patient has a family history of hypothyroid. Okay, this is the way you have to go about hypothyroid. Should euthyroid patients with benign thyroid nodule be placed on thyroid hormones suppression therapy? There is a small nodule. I tested. All the hormones have come normal, but let me give some thyroid. No. What are you talking? You should speak scientific. Never give for a non-normal functioning nodule. It could be malignant. You may think that you have given some tablet, patient feels happy. After 1 year, she comes, sir, the neighboring doctor diagnosed this as cancer. I'm suing you now. That's what will happen. So don't treat like that. So we need to apply the current treatment knowledge. Knowledge in the book or in the mobile phone or in the laptop is no use unless applied. So you have to apply the knowledge. Okay, with this I will close this hypothyroid business. Then I will show you some slides on the hyperthyroidism. Some questions yesterday. These questions you should be able to answer.
The patient complains of sandy sensation in the hands, weight loss, and tremor. His extraocular muscles are inflamed. His thyroid is diffusely enlarged and non-tender.
What is the likely diagnosis? What are the things there in the clinical history, the presentation?
The sandy sensation size.
Means what? Ophthalmic symptoms are there. Weight loss, general symptom is there. Tremor, specific hypermetabolic tremor is there. Extraocular muscles are inflamed. That's also ophthalmopathy. And enlarged thyroid is there. And non-tender. Non-tender means what? Only one tender thyroid. Subacute thyroiditis only is tender. Tender. This is diffusely enlarged. Diffuse enlargement is Graves. Okay. So ophthalmopathy is there. That's why it is Graves. Ophthalmopathy, extraocular muscle involvement, sandy sensation, tremor, loss of weight, enlarged gland, diffuse, non-tender. Graves diagnosis. Is it why it is not multinodular goiter? Because it is diffusely enlarged. Why it is not subacute thyroiditis? It is tender. Why it is not iron deficiency goiter? The patient is having hyperfunction. Iron deficiency goiter will have hypofunction. This have hyperfunction. Okay. Case number 2.
A 55-year-old woman is anxious, irritable, frequent semi-solid stools, and she reports weight loss of 5 kgs in the past 6 months. She was having a lumpy pain with swelling in her neck for the past 20 years. The most likely diagnosis is.
First, understand the clinical description. She is a woman, very good. Woman only get thyroid disease. Yeah, second thing, she is irritable. Even every woman is irritable. Fine. She is having fancy, yeah. Here is a specific history. Frequent semisodal stools. Okay, there is high increased bowel movement, loss of weight, 6 months. Okay, and the thyroid gland on palpation is lumpy, puppy thyroid gland. And 20 in her neck for 20 years she is having. Now it has become bigger and all these things. What is the diagnosis? Iodine deficiency goiter will not be lumpy bumpy. She has no business to have loose stools. She has no business to be irritable unless her husband is very bad. Never produce hypothyroidism. It produces hyperthyroidism. Graves' disease, the diffuse enlargement, not bumpy, lumpy, tumpy thyroid. Okay, and this one no ophthalmic symptoms are anything is reported. Solitary toxic adenoma also will not be lumpy bumpy. So it looks like it is multinodular goiter. How do I confirm the diagnosis? The radio didn't demonstrate multi. Yes, number three.
A 60-year-old patient from a mountain region complains of constipation.
Mhm.
He has a heart rate of 60, very thick skin, and a tongue that has scalloped edges from teeth indentation. Has a goiter.
See, 60-year-old patient is in the mountains. Okay, very good. Their iron will not be there. And then bradycardia is there, dry skin is there, thick skin is there. Everyone is thick skin nowadays. Even if you say something, they don't listen. Okay, tongue is already scalloped, macroglacia with scalloped edges. This also has got a goiter. What sort of goiter is that? Iodine deficiency goiter. Subacute thyroiditis will be hyperfunctioning, Graves is hyperfunctioning, silent thyroid has no business to have any increased size of the thyroid gland, and no constipation is not a feature of that. Constipation, bradycardia, dry skin, scalloped edges, macroglacia are all pointing to hypothyroid. Being in mountainous region, the reason for hypothyroidism is lack of the raw material. Factory is working well, but there is no raw material going into the factory to prepare the product. So iodine is not there. 4.
Uptake is very high in the thyroid of patients.
What is happening is you do a nuclear scan. Very high uptake is reported in which condition? Single functional adenoma, only that localized area it will subacute thyroid. Never, it is not going to increase. Acute ingestion of animal thyroid extract. What does it got to do with this? Graves' disease, very profound increase in the radioiodine uptake.
A 72-year-old man complains of tremor and inability to concentrate on exam. He has
I think I should correct this slide. 72-year-old man, not old man. 72 years. 72-year man. If you say that man old, I also will become old. Okay, 72-year-old man.
complaints of tremor and inability to concentrate on exam.
That is there in all our students, inability to concentrate. Not a new feature for him. Okay, on exam.
He has a heart rate of 100 beats per minute. He has
Yeah.
a large goiter with many nodules. He has a faint tremor. His serum FT4 is very high and PSH is very low. Treatments that are likely to.
Now we are not asking the diagnosis here. It is very evident. He has got multiple nodules, FT4 high, TSH is very low, elderly person, and tachycardia is there, multinodular goiter. Okay, what we are asking is treatment that are likely to improve. How do you treat multinodular goiter? In other words, we are asking. Ethanol injection into the thyroid. What is that? PA is what? Percutaneous ethanol injection. There is a treatment like that, percutaneous ethanol injection. It is this we do it as a alcoholic ablation for certain small papillomas and things like that. It's not here. Okay. 6 weeks of methimazole treatment. Good. Try that. If it doesn't work, radioiodine. the best treatment would be radioactive iodine. Since he is not a pregnant woman, definitely it can be recommended, isn't it? So age is important, sex is important. Gender, that's a 72-year-old man. Okay, old man. Okay. These are the stories. Now I want to show you one more algorithm. With that, we are going to close the class.